Good morning. Welcome to General Surgery's Grand Rounds. And this morning, it's my pleasure to introduce Dr. Andrew Adams. Dr. Adams grew up in Guyana, and he went to college there and then medical school in the Caribbean, and joined our residency and spent 1 year in the lab. He is graduating, allegedly, in June. And is pursuing a private practice private practice group in Kansas City, Kansas, or Dodge. I'm always joking about Dodge. Get out of Dodge. Yeah, Dodge City, Kansas, the infamous Boot Hill. So hopefully you won't put too many of your patients in Boot Hill, Doctor. Please help me welcome.
Good morning, everyone. So this morning I'm going to present on inflammatory bowel disease, and I chose this topic for several reasons. First being that I'm very interested in this particular area, and also because I think it's useful for a general surgeon to have knowledge of how to treat these patients, because most likely in our careers they will present to us, and a sound knowledge of the basics of treatment is very important. And so hope to be able to present some useful information this morning on the treatment of inflammatory bowel disease. I do not have any disclosures. My layout of my talk will be following this pattern. So I'll define the conditions, go into a little bit about the history and epidemiology, how they are diagnosed, extraintestinal manifestations, medical management, the risk of cancer, and then surgical management, and any future management strategies that are on the horizon. I'll also be talking about a little bit about IBD and pop culture and some funny stories, hopefully they're funny, and giving some historical perspectives as I go along. So whether you believe this quote or not, you might think it's a bit extreme if you do not have inflammatory bowel disease. But for the sufferers of this disease, who can have diarrhea of up to 30 times a day, severe cramp and abdominal pain, fatigue and weakness, this statement might be particularly true. A good, reliable set of bowels is worth more to any man than any quantity of brains. So to define them, ulcerative colitis is a chronic inflammatory condition that causes continuous mucosal inflammation of the colon. It affects the rectum and a variable extent of the colon in continuity, and it's characterized by relapsing and remitting course. Crohn's disease, on the other hand, is also a chronic inflammatory disease, but it has transmural inflammation with skip lesions, and it can involve any part of the GI tract. So a little bit about the history of these diseases. They probably were not existed long before they were named. We've had Hippocrates describing multiple etiologies of GI disease, and many associated with diarrhea. But the first use of the word ulcerative colitis was by Wilkes, and he described several patients who had the chronic diarrhea and inflammation and bleeding. And then in the 1910s, we had more detailed descriptions, and surgical treatments began to emerge. And as science progressed, we had pathologic and radiologic descriptions and development of drugs that could treat them to varying degrees of efficaciousness. In Crohn's disease, followed a similar course. Various descriptions in the early 18th century that would today be defined as Crohn's. But the first case series was about 14 patients and was done by Dalziel. And then we had the landmark description in a paper by Crohn, Ginsberg, and Oppenheimer. Disease is named after Crohn, of course. And then it was found to be, at that time, a little later, it was found to be separate or described separately from ulcerative colitis, and description of it being found throughout the gut. And then we proceeded with various endoscopic methods of diagnosis and studies of genetics. Ulcerative colitis, the incidence is about 12.2 per every 100,000, so about 38,000. And Crohn's is about 10.7 per 100,000. Prevalence of 900,000 for ulcerative colitis and 780,000 for Crohn's. UC's peak age is 15 to 35. Crohn's has two peaks, 15 to 25, and then more common again in the 55 to 65-year-old. In terms of race, the unfortunate Ashkenazi Jews have the highest rates, and then Asians are diagnosed at earlier ages. And the kind of evidence for a environmental causative factor is that immigrants from other countries where the rates are low, when they come to countries that have higher rates, they develop the rates of the communities to which they move. It's mainly a disease of the developed world, with Canada having one of the highest rates of ulcerative colitis, and Denmark having the highest rates of Crohn's. Interestingly, the rates in the developed world or the Western world have been reaching a plateau over the past few years, but the Asian rates have been growing. I don't know if that's as a result of globalization or westernization, but this is the trend that we're seeing. The etiology of these diseases, we do not know the exact cause, but we think that there are multifactorial etiologies involved, mainly genetics, immune disturbance, and environmental triggers. And as we talk about genetics, we know that about 5 to 20% of people with inflammatory bowel disease have a first-degree relative with one of the diseases, and about 36% of people with both parents affected develop IBD. Evidence for the immune system disturbance, there have been about 100 genes with different loci that have been linked to inflammatory bowel disease. Most significantly, the NOD2 and the CAR, the 1,5 for Crohn's disease, and the PANCA for ulcerative colitis. And it's postulated that disturbance in the immune system causes a lack of ability for the person or the patient to respond appropriately to bacterial penetration. So they have a hyper-inflammatory response, which leads to the findings and the symptoms of the disease. Various environmental factors have been thought to play a role in the causation of these diseases. Contamination of water sources is a theory that's been postulated. Food additives and sugar consumption may be linked. Interestingly, smoking increases the risk of Crohn's disease, but decreases the risk in ulcerative colitis. And prior appendectomy is often protective for ulcerative colitis. So the diseases are diagnosed with a variety of modalities. Since there is no specific pathognomonic test or serology marker that tells you whether you have Crohn's or ulcerative colitis, it's a combination of history and physical, laboratory, endoscopic, and radiologic findings. Most commonly for patients complaining of pain and weight loss, fecal urgency and incontinence for Crohn's. Ulcerative colitis, there's more evidence of bloody diarrhea, urgency, tenesmus. Both have extraintestinal manifestations. And so when a patient presents with these kinds of symptoms, you have to rule out common causes. So stool studies, CBC, we're looking for infectious causes, inflammatory markers, and then these would be the diagnoses of exclusion if the other studies are negative. For endoscopy in Crohn's, since it occurs from the mouth to the anus, we have to do EGD and capsule endoscopy and colonoscopies with ileal intubation to visualize the entire GI tract. For ulcerative colitis, most likely we do a colonoscopy with ileal intubation or a flex sigmoidoscopy, and we would be able to get biopsies and sufficient sample for diagnosis. And of course, radiologic studies such as CT, small bowel follow-through, CT enterography, all help to kind of nail down the diagnosis for these. See, here we have a typical lead pipe loss of haustra in a contrast study of the small bowel. And here is a description of the comb sign, where you have mesenteric thickening along the bowel, and this looks like the teeth of a comb. So these are some of the findings that we find when we do these studies that help us to get better, to nail down the diagnosis better. Of course, the diagnosis is pathologic, and so these are some of the pathologic findings that we have as compared between the two diseases. So in ulcerative colitis, you seldom have transmural inflammation, whereas in Crohn's it's very common. Granulomas are common in Crohn's also. Significant perianal or extraintestinal disease is very common in Crohn's, such as fissure and fibrosis. anatomic location that's very important. For UC, it's continuous. For Crohn's disease, it's skip lesions. Rectal involvement, very common in UC. Rectal sparing is common in Crohn's disease. And so these are the pathologic findings that help us to kind of determine. And in the face of all of this, there's still about 8 to 10% of cases that have so much overlap that we have called them indeterminate colitis. And so the diagnosis is not as clear. For instance, in Crohn's disease, you can have backwash ileitis, which would confuse the picture. In ulcerative colitis, you will have backwash ileitis, which could confuse the picture between the two diseases also. Both diseases have extraintestinal manifestations, and they can affect any organ system. So the eyes, uveitis, episcleritis, the skin, pyodermal gangrenosum, erythema nodosum. We have aphthous ulcers, the biliary system with primary sclerosing cholangitis. And these manifestations are affected to varying degrees by surgical treatment. So as we move on to medical care, I found it particularly interesting that in the early days of treating these diseases, there were a therapy called organotherapy, where they fed raw porcine small bowel to patients, which is, not many of them responded well to it, but this was one of the medications that was tried. And then ionizing therapy, where the entire bowel was irrigated with zinc solution, and then an electric current was shot through it. These were in the early days. Today, medical therapy is the mainstay of management, but about 30% of patients at UC at least require surgery at about 10 years. And failure of medical management is the #1 cause for needing surgery. Disease severity is graded on different scales, and the grading systems help us to design therapies and also to study the diseases better. The True Love and Wits severity scale for ulcerative colitis defines it into mild, moderate, and severe based on diarrhea, hematochezia, heart rate, temperature. And the Crohn's disease activity index goes by a number of items, such as number of stools per day, abdominal pain, arthritis, etc. Each item has a weighting, which is added up, and that tells you the severity of the disease. And it allows us to tailor our therapies towards it. So activity index in Crohn's less than 150 tells us that there's symptomatic remission, whereas in ulcerative colitis, less than 4 stools per day without bleeding or urgency is what we say is for symptomatic remission. Medical management is, of course, predicated on anti-inflammatory treatment, and they're divided into 2 groups. Groups of drugs that cause induction of remission and those that are used for maintenance therapy. So we have the aminosalicylates, steroids, biologics that are used for induction of remission, and then for maintenance therapy, we have the aminosalicylics, again, biologics, and the anti-tumor medications. All of these are anti-inflammatory. Biologics are the newest and the most efficacious treatments. They're based on antibodies to tumor necrosis factor alpha. And so there are various methods of treating these patients medically. Generally, over the years, we've used the bottom-up approach, where the least efficacious but least toxic, least expensive treatment is started first, and based upon the patient's response, we go up. So generally start with aminosalicylates. If they don't work, go up to corticosteroids and immunomodulators, and then finally we end up with biologics or surgery. However, interestingly, over the past few years, the top-down approach has been advocated, where the most efficacious, most potent drugs are used first in an effort to attack the disease at the start, especially in medication-naive patients. And then that way decrease their risk of recurrence, decrease their risk of extraintestinal manifestations, etc. And then, so we start with those, and when we have achieved remission, we start to go down to see what drug they can be maintained on. There are proponents for both treatment approaches, and depends on the patient's presentation, the one that you would choose the most. And this is a typical treatment algorithm that's used in ulcerative colitis. So for mild disease, oral or topical sulfasaline. If it's moderate, start with steroids. Or if the oral topical mesalamine fails in 2 to 4 weeks, we can go to steroids. And then for severe cases, admit for IV steroids, we start with the two immunomodulators, infliximab, biologics, etc. And if that fails, then we go on to surgery. Now, as a surgeon operating on these patients, it's important to know what medications they're on and what effect the medications will have on perioperative risks. So generally, aminosalicylates have no effect on perioperative risk, so they can be continued up to surgery and restarted immediately after. Steroids have increased infection risk, as we know. Poor wound healing can cause adrenal insufficiency, and so would need stress dosing. And then antibiotics increase the incidence or prevalence of C. diff, but not really an effect on wound healing, etc. Immunomodulators, interestingly, have no effect on perioperative risk. Biologic agents, they do. So it's recommended to stop their therapy about 30 days prior to surgery. Of course, it's difficult because most of these patients present for surgery when they failed maximal medical therapy. So they're already on biologics, etc. And so it's hard to say, wait 30 days before you get your surgery, especially if it's emergent. So over the past few years, we've had many trailblazers who've been trying to remove the stigma from the ostomy and trying to make it clear up the misconceptions associated with it. The first on this picture, Jess Grossman. She's the founder of uncoverostomy.com. And she, through sharing her personal experiences and modeling, etc., has tried to decrease the bad perceptions that the ostomate can sometimes find in the outside world. Next is the bodybuilder, Zoe Wright. She was 22. She has a total colectomy. She was diagnosed with ulcerative colitis, and she has an endoleostomy. She went on a few months after her surgery to actually go ahead and win the bodybuilding competition in England. And then we have Blake Beckford, also had a subtotal colectomy with endoleostomy, and went on to perform and win a male fitness model competition nationally. And during the competition, he wore his ostomy bag to be displayed proudly. And so these have been kind of pushing the envelope and trying to remove the stigma of the ostomy. And of course, it would not have been possible if the ostomy appliance itself had not undergone a great evolution in terms of its design. The first descriptions of the ostomy appliance were in the 1700s, and then it was just a piece of sponge with a bandage. That was what all it was. And then over the next few years, we went to tin cups, plastic bottles, various rags strapped to the stoma. And even up to the 1930s or 1960s, we had rubber ostomy appliances that were bulky, leaked a lot. The odor would be absorbed into the rubber, and so they had to be cleaned very frequently. We had this type, this was from the 1930s, where air had to be, it's like a tire, air had to be filled in there to various heights, but then the air would be let out and you'd have leakage. And then this was a 4-piece, very bulky, very uncomfortable ostomy appliance. This was from the 1960s. And so these have all been where we started. This is what we have today. So it's odor decreasing. It has a vent for flatus. They're changeable. They're low profile. And so this change over the past few years has caused the ostomate to really have a better quality of life when it comes to the appliances that they wear. So we all know that cancer risk is greatly increased with patients who have inflammatory bowel disease. We have multiple studies elucidating the risk, and so a meta-analysis from Europe in ulcerative colitis, the risk of about 20 years is about 8.3%, 30 years 18%. Another in Crohn's disease, risk is about 5.6% in 20 years, 8.3 by 30 years. And in the Korean trial, the risk by 30 years is about 32.5% of patients who develop cancer who have inflammatory bowel disease. And so they need screening. And the screening, according to the NCCN practice guidelines, if you have a personal history of inflammatory bowel disease, about 8 to 10 years after the onset of symptoms, you have recommended to have a colonoscopy every 1 to 2 years. It's important that the colonoscopy should be done in periods of quiescence, so not during a flare, because during a flare, you can miss cancer. You have to wait till the flare is passed, the disease is quiescent, and then you can do the colonoscopy. And we use multiple biopsies. About every 10 centimeters, you take about 4 quadrant biopsies along the entire colon so that you have samples that can be sent to the lab. And you do extensive sampling of strictures and masters. This is, of course, very labor intensive, and there is a big chance of missing a malignancy. So they have improved this screening procedure by using chromoendoscopy, where you use a blue dye sprayed onto the wall of the colon, and as you do a colonoscopy, it lights up areas of abdominal mucosa, which causes us to have more directed sampling of abnormal areas. Goes on, if you find dysplasia or neoplasia, you have to go on to surgical consultation for resection. So early surgical therapy varied from simple, like therapeutic pneumoperitoneum, which was very efficacious in intestinal TB, but didn't work so much for inflammatory bowel disease, to appendostomy, where the appendix was brought up to the level of the skin, and it was a catheter was introduced, and you had an irrigation of the bowel. To prefrontal lobotomy, this was tried for inflammatory bowel disease because of the severe psychiatric ailments that are common in patients with inflammatory bowel disease. To vagotomy, pelvic nerve dissection, which had severe effects on function. And then these were the first setons that were made of horsehair. This was from the 17th century, or pieces of cloth, and they had specially designed needles to introduce them into the skin to help drain fistulae and abscesses. But surgical care for ulcerative colitis, when do we do surgery? So they're divided into when we do urgent surgery and when we do elective surgery, of course. Urgent surgery is any case of toxic megacolon perforation, severe bleeding, severe colitis. Elective, mainly due to failure of medical management, cancer, cancer prophylaxis, and for dysplasia. In terms of the extraintestinal manifestations, benefit from surgery is seen with erythema nodosum, arthritis, and the eye diseases, but surgery has no effect on the primary sclerosing cholangitis, ankylosing spondylitis, or sacroiliitis. Emergency surgery, the best procedure would be subtotal colectomy with endoleostomy and Hartmann stump. It's quick, remove the source of the patient's symptoms, and you preserve the rectum, because in a UC patient, you should always try to preserve the rectum in emergency surgery, because they could benefit in the future from pelvic procedures. How do you treat the rectum that's preserved, though? So, suture or staple the proximal end. If it's very friable, you can leave enough sigmoid to create a mucus fistula to the anterior abdominal wall so it drains and doesn't have a blowout. And if it can't reach the skin but can at least reach the fascia, you bring it up to the fascia and suture it in the subcutaneous space. If you can't suture it, then put a Foley in the stump, bring it out to the lower end of the abdominal incision. Transanal drainage is also particularly efficacious in preventing rectal stump blowout. And if you do use any of these, you have to widely drain the upper stump end. Most of these patients will eventually need a proctectomy. And if the rectal stump is intended to be permanent, they will, of course, need lifelong surveillance because there's still a 10% risk of rectal cancer. Now, for elective surgery, there are many procedures based on the patient's symptoms, location of the disease, and health status. Total proctocolectomy with endoleostomy, surgically removed anus, ileum nips, all of the cancer risk, no fecal urgency or frequency. If there is sphincter dysfunction, then this is the operation of choice. Of course, the patient has a permanent ileostomy, so that is something that they need to be counseled about extensively. Colectomy and ileorectal anastomosis. Sometimes done if there's relative rectal sparing of the disease. There's an increased fecal frequency, but there's no morbidity from pelvic dissection, which is great in some cases. About 10% of these patients go on to require a proctectomy because they have poor function and they have proctitis. So this disease, this procedure is most used in patients who have minimal rectal disease and who want to preserve their parasympathetic nerve function and continence. The cock pouch. So this really is not performed much. It's more of historical historical interest now. But basically what it did was prevented the patient from having ostomy of the skin. So it's an ileal reservoir made from terminal ileum. It had a valve made from you intercepted ileum into the pouch and secured it with staples. It was on the level of the skin and had to be catheterized to be drained. However, complications from it were very frequent. There was a 50% revision rate due to slippage, incompetence, fistula, and so it's not really much performed today, especially given the great usefulness of the restorative proctocolectomy. Otherwise known as the ileal pouch anal anastomosis. It's an adaptation of the cock pouch, interestingly enough, but removes the cecum, colon, rectum, and may or may not remove the distal rectal mucosa. And you make an ileal reservoir and anastomose it to the anal canal. So patient selection for this procedure is very important because you have to manage their expectations. They have to know that they can have an average of 6 bowel movements per day. They can have some nocturnal incontinence. They have a fair ability to discriminate between gas and stool, so prevents accidents. But if the patient cannot deal with these possible side effects from the procedure, then they should be offered another surgery. And so this is basically how it looks. The pouch is created and you join it to the anus. It's often done in a 2-stage procedure, sometimes a 3-stage. So most times we start off with a proctocolectomy, create the pouch, and do proximal diversion. And then later on, so the reason for this is to protect the pouch that's created. And later on, after you've studied the pouch and there's no leak and the anastomosis is good, there's no stricture, then you can offer takedown of the ileostomy. 3 stages is done if the patient is very ill or malnourished or has very low serum albumin. And so first stage, we do an abdominal colectomy, leave the rectum, bring out an ileostomy. Then you do a proctectomy and form the pouch as the second stage and do a diversion procedure at that time also. And then the final stage would be a takedown of the diversion procedure. The pouch is created by stapling 2 15 to 20 cm limbs of the ileum together and making an enterotomy at the apex of the pouch, and then firing 2 or 3 loads of the GIA to make the length of the anastomosis. So you accordion the ileum onto it, fire, accordion it some more, fire again. And then this is where the apex, where the enterotomy is made. There are various other pouches that have been performed for various regions, but the J pouch is of course the most useful and the most efficacious. So an S pouch uses 2 limbs, 10 to 12 limbs, but it uses the efferent limb as the anastomosis. So it has a little bit more length than the J pouch, but has a lot of difficulties with evacuation and not been found to be much more useful than the J pouch. And then there's the W pouch, which was developed to increase capacity, but there's no difference in function and soiling, etc., as compared with the J pouch. So the J pouch has emerged as the winner in terms of pouch surgeries. So whether we do a staple anastomosis or a hand-sewn anastomosis is the next point of discussion. So for the staple anastomosis, you transect the very distal rectum with a stapler, and then you use the EA, perform a circular end-to-end anastomosis right there. With the hand-sewn, you have to infuse the submucosa with dilute epinephrine, strip off the mucosa from about dentate line to 2 to 4 cm proximally, take out the rectum, remove the tube of the remaining tube of the rectum transanally, and then make a hand-sewn anastomosis there. So the staple anastomosis preserves the anal transition zone. So you have enhanced function, because you have enhanced retained sensation and continence. There is an increased risk of neoplasia in this small area of retained rectum. The hand-sewn anastomosis removes the transition zone, so you lose that function and sensation. However, the reason for the hand-sewn anastomosis is to decrease the risk of neoplasia associated with the staple. However, there is still a small risk because small islands of mucosa can still be left, and so the risk is not zero, even with removing and so these patients also need surveillance continually. The next point that we discuss is how do we get the J pouch to reach to the anus? If the patient is very tall or obese, you can have some difficulty because the rim sometimes does not reach comfortably. If this happens, mobilization of the small bowel mesentery takes place, the third portion of the duodenum. So you lift up the bowel and you just score the mesentery all the way. All the peritoneal attachments surrounding the vascular mesentery are divided. And so a good test to make sure that it will reach is that when you bring it down to the symphysis pubis, it should extend about 3 to 6 cm beyond it. Additional techniques for gaining length: transverse incisions of the peritoneal layers on the mesentery bilaterally, so along the vessels, make transverse incisions to gain length. And then after you mobilize, you can trans-illuminate the mesentery and see the vascular anatomy. And some division of the distal branches of the ileocolic or SMA is permissible if you can be sure that there is adequate anastomosis that are left. And you can test this by placing a bulldog on the vessel intended for transection and see if a pulse remains. If the pulse remains, it means that there's good collateral flow. You can take that vessel. Late complications of the pouch. 30–50% people get pouchitis, generally treated with flagyl and like Cipro or mesalamine. Small bowel obstruction occurs in about 26%. Bowel rest is the mainstay of treatment, reoperation at about 28%. Cophitis, so the small bit of cough that's left, about 5 to 14% get it. It presents similarly to ulcerative colitis, so you get the pain, diarrhea, bleeding, treated with steroid suppositories or mesalamine. Pouch failure occurs in about 5 to 10%. You have to think about this. If the pouch failed, was this patient misdiagnosed? Did the patient have Crohn's instead of ulcerative colitis, and hence has developed fistulas, etc., causing pouch failure? Treatment of pouch failure generally with biologics. Fistulae, depending on the type, you can excise, divert, antibiotics, drain abscesses. Sexual dysfunction occurs in about 5 to 20% due to the pelvic dissection that's needed. Viagra, penile rehab, estrogens, androgens used for treatment. Risk of cancer is rare, but it does exist. You need surveillance and treatment of cancer if developed. Strictures need dilation or revision. So let me see if I can get through this slide with a straight face. So for those intimate moments when a big pouch of stool will get in the way and spoil the mood, we have trailblazing companies like Myostomy, which have prepared a whole line of discrete ostomy appliances that include ostomy plugs that are jeweled. We have cover-ups. We have, and the ostomy plug is actually very versatile. It plugs the ostomy and it has a small bag that's attached that doesn't need to be drained for about 1.5 hours. And so these companies have kind of improved the lives of ostomates through the centuries by their developments. Crohn's disease surgical care. What are the indications? Failure of medical management, obstruction, abscess and inflammatory masses, fistulae, bleeding, toxic colitis, and cancer. Basic principles of Crohn's surgery. So these patients will probably in their lives need a lot of surgical interventions. So it's super important to try and preserve bowel length. You need to fully explore the abdomen because about 50% of fistulae are not detected on pre-op imaging. Thorough pre-op evaluation, imaging, surgical history, medications, because that has an effect on the surgical procedure that you do. The bowel can sometimes be severely thickened. So hand-sewn anastomosis may be better in that case. You have to counsel the patient that the surgery is not curative, and about most patients will end up having about 2.5 surgeries in their lifetime. For small bowel Crohn's, the mainstay of surgical procedures are strictureplasty, bypass, and resection. Indications for strictureplasty: non-phlegmonous fibrotic strictures, isolated colonic strictures, diffuse involvement of small bowel with multiple strictures, and short gut. Contraindications: impaired nutritional status, dysplasia, or sepsis in the area, such as phlegmon abscess or peritonitis. It's important to note that Crohn's disease cancers do not necessarily present as masses, and so any strictureplasty that's done where you're not excising bowel, you should always biopsy, because there is a risk of a cancer being located in that area. The types of strictureplasties: for short segment, less than 7 centimeters, you have the Heineke-Michalux. Intermediate, up to 15 centimeters, the Finney. And then multiple short strictures over a lengthy segment of bowel, we have the Michalazzi or side-to-side isoperistaltic. The procedure for the Heineke-Michalix, most surgeons are comfortable with this. Make a longitudinal incision along the antemesenteric side of the bowel. You go 2 cm proximal distal to the stricture, and then you close it in a transverse fashion in 2 layers. This way you open the bowel, you do not narrow it, and you get a wider lumen at the area of the previous stricture. The Finney, which is for longer length strictures, fold the stricture loop over on itself at its midpoint, make a longitudinal enterotomy along, and then you basically suture it in 2 layers together, and you create a short enterostomy. This way you have a widened lumen in this area also. And then finally the Michalazzi is where you fold the 2 layers of bowel over each other, make incisions along the anterior surfaces of both, and then you suture these 2 together and these 2 together, that way widening the lumen of the area. For resection procedures, most times patients can tolerate resection with primary anastomosis. You need a margin of about 2 centimeters of grossly normal appearing bowel. So because bowel length is so important, slight inflammatory changes to the bowel that you're going to leave is not an indication for excision. If there's short amount of fat creeping, etc., you can still preserve that bowel. If it's severely inflamed, is the reason that you would go and excise that. If it's very thickened, hand-sewn anastomoses are safer. Thickened mesentery, you need to suture ligate and clamp, because stapling or ligature, etc., may not hold the vessels, and you have bleeding, dangerous bleeding after. Side-to-side anastomosis associated with decreased leak rate, and if they have severe malnutrition or fecal contamination, they may need a stoma instead of a primary anastomosis. And then the bypass procedures. So you exclude a proximal, you bring a proximal end of bowel up to exclude a disease segment. So, for example, in this picture, this segment is disease, you bring out ileum to this transverse colon, and you bypass the disease segment. And this can be definitive, or it can be a kind of a stopgap to a more definitive procedure in the future when the active inflammation has died down. So who are these people? Anybody? Who's this gentleman? Anybody knows? There you go. And this lady? Yes. All right. What do they have in common? They're all famous people who have IBD. So Eisenhower actually had a bypass, an iliotransverse bypass, while he was in office. Shannon Doherty, throughout her years on 90210, was suffering with Crohn's. Marvin Bush, the eldest, one of the sons of President Bush, actually has an ostomy after an emergent colectomy. Amy Brenneman, she has a J pouch. She's from Judge and Army. Not sure whether or not JFK had colitis. He was sick for many years, but was never diagnosed formally, but many people believe that he had ulcerative colitis. Darren Fletcher, player for Manchester United, who has a J pouch and continues to play. So what do you do for Crohn's disease of the colon and the rectum? Segmental resections are options if you have segmental colitis and the anus and rectum are spared. You maintain the absorptive length. The patient does not need an ostomy, but 30 to 70% of people will have recurrent colitis. If you have extensive disease, you cannot do a segmental resection. You need to do a total proctocolectomy, bring out an end ileostomy. There's a subgroup of patients who have extensive disease but have anorectal sparing, and so you can do an abdominal colectomy for them and do either an ileorectal or ileoanal anastomosis. 50% of them will eventually require rectal excision and a pulmonal stoma in 25%. If you have rectal Crohn's, then you need a proctectomy and a permanent stoma. Try to preserve the pelvic nerves so you stay close to the rectal wall. You can do intersphincteric resection if there's not significant perianal disease. And if you have severe perianal disease, then you need to do a wide perineal excision and maybe a gracilis or rectus muscle flap. Abscesses, perianal abscesses in Crohn's are, of course, more complex than they would be in the normal patient. Most of them require drainage under anesthesia. MRI perioperatively helps to give details of the tracts and relation to the sphincters, and ultrasound also can be helpful in identifying the tracts. Fissures, you get two types. The standard type is an anterior or posterior fissure. This is normally associated with sphincter hypertonia, very painful. Crohn's fissures, generally off midline and broad base, not necessarily associated with increased sphincter pressure, and generally not painful. If they are painful, think that there's an underlying abscess. For treatment, conservative management is initially tried, so sitz baths, ointments, stool softeners, etc. for normalization of bowel function, nitroglycerin or nifedipine, and then surgery is only considered in painful refractory lesions. Sphincterotomy should not be performed for broad-based off midline lesions or those with low sphincter tone, only used for midline lesions. You do an EEA, search for abscesses, debridement of fissure edges as part of the surgical care. Fistulae in ano, asymptomatic. If they are asymptomatic, they require no treatment. If there's an abscess, you drain it like you would drain an abscess in a normal patient. You can do a fistulotomy if the tract is low and the anorectal disease is controlled. Get into more advanced treatment modalities, anorectal advancement traps for higher tracts, and then the draining seton can be used for extended periods. So some Crohn's patients can have the draining seton for 10, 20 years. Try not to use a cutting seton in a Crohn's patient. So given the difficulty that many inflammatory bowel disease sufferers have in monitoring symptoms, finding restrooms, etc., there's a variety of apps that are available for them. So apps such as Poop Time or Sit or Squat actually give them a GPS location of the nearest restroom so they can have access quickly. Apps like GI Monitor and GI Buddy help them to monitor their symptoms, their meals, and give them a kind of a social network in which to talk to other similar sufferers from inflammatory bowel disease. Fistulae. So if there's an enterocolic fistula, if you have an iliosigmoid fistula and the sigmoid is not diseased, then you can try to close it with a colotomy on the sigmoid while you excise the fistula. The only reason to resect the sigmoid would be if there's mesenteric involvement and it precludes closure of the colotomy. Most times you have a fistula from disease segment to innocent bystander, and so therefore if you take care of the disease segment of bowel, innocent bystanders such as bladder, vagina, etc. will heal with minimal intervention. So resect bowel that's diseased and involved and leave the other organ maybe simply closing or draining will help healing in that stage. Urologic fistulae. So fistula to bladder respond to bowel resection and then just simple decompression of the bladder with a Foley and or closing the sinus on the bladder and draining with a Foley. For rectovaginal fistulae, You don't necessarily always have to do proximal diversion. There's a high rate of recurrence and sometimes leading for a proctectomy to be done. You can do transanal repair for low fistulae, excise the fistula, the mucosal advancement flap, leave the vagina open for drainage. Higher fistulae need LAR or coloanal. So what's the future as we talk about inflammatory bowel disease? There have been several studies for fecal transplant, which has been efficacious in some cases of ulcerative colitis. Stem cells are being evaluated for injections into and around the fistulous tracts in Crohn's disease. And different biologics with different mechanisms of action and anti-integrins are being developed that target specific inflammatory markers and would help us to have more targeted therapy. Manipulation of the microbiome, so using antibiotics, probiotics, dietary changes, etc., being evaluated also. Be able to monitor the effect of the drug better, so there are various monitoring systems are being developed for this. And then treating to mucosal hair healing. So this is not generally right now the standard of care. We treat to symptom relief, but they've been advocating treating to mucosal healing, so the mucosa must be totally healed, and that might become the standard therapeutic goal in the future. And then a cure. We're a ways from that, but it's always a possibility as we find out more about the disease, that becomes more of a reality. There's a lot of support for people with colitis. There's the Crohn's and Colitis Foundation of America, the Crohn's and Colitis Foundation of Canada and European. There's support for teens with Crohn's, and all of these have websites, social media discussion groups. They have support lines, etc., that help the sufferers of inflammatory bowel disease. There's actually been a development of a medical alert restroom access required card that inflammatory bowel disease users can carry around with them when they need urgent access to a restroom. And so all of these organizations are trying to improve the lives and the lots of these patients. So acknowledging Dr. Logue and Dr. Dow for their help and guidance in this presentation, for their slides, help with slides, etc., and for their patience in teaching residents. And I can take any questions now.
You could probably give a separate grand rounds on just a lot of the myths that are associated with these two diseases. Yeah. Dr. Ramos, Dr. Arthur Alspies was the chair at Mount Sinai where Crohn was. And he always used to talk that it wasn't really Crohn. Is that just an urban myth, or?
You have to do with the initials. You know, you start with a C and then with an O. Oppenheimer was the last guy. So
he was the brains behind it.
That's the difference. But I think that it's a very complex subject to be given in 45 minutes.
Yeah.
And you did very, very well.
Thank you.
And there are a few things that need to be emphasized. Yes, we have made a lot of progress on the appliance, but important progress was made by one guy, and that was the guy that modified the ileostomy before there